Happy Thursday, everybody. We are excited about having you join us again. This is the fifth of our 8 webinar series. And today's session is titled Strategies to Optimize Care Coordination Through Telemedicine. And we are excited to welcome back Mary Blankson. She was with us previously on one of our other webinars, and we're excited about having her join us again. I understand she's had a little interesting week with the hurricane, the storm that moved up the East Coast, but we're excited about having her back and is still able to join us today. Maybe from a little bit different location though. So just a reminder, I have everybody muted. If you have any questions throughout, you can put those questions in chat box. I will open up the mics at the end of the session, and if you want to speak verbally, feel free to do that, to ask questions, make comments, and then you can also put your questions into the chat as well if you don't want to ask verbally. So today, this is going to be a session where we're able to offer CE. So let me move forward here. So today, I just want to share a little bit the disclosures. Nobody has any kind of commercial interest that was engaged in the planning of this webinar, and neither does our speaker. The CME has been applied for through UAMS and has been filed with the American Academy of Family Physicians, and so there is CE pending through that organization. So we're excited about that as well and being able to offer that for you. I do need to go over quickly the learning objectives for today's session. First off, defining care coordination as a process is one of the learning objectives, describing team roles within the context of care coordination, describing components of care coordination and associated tools needed for successful implementation, using Community Health Center, Inc. as a case example with regard to best practices and lessons learned. And then lastly, identifying specific telemedicine strategies that support and enhance existing care coordination programs. So I'm going to introduce Mary at this point, and then I'm going to turn it over to her. So I'm going to go ahead and stop my share. Mary, if you'd like to go ahead and share your screen, feel free to. So Mary Blankson is an APRN and is the Chief Nursing Officer with Community Health Center, Inc. She oversees diverse nursing services across the Community Health Center network, including primary care, health care for the homeless, and school-based health services. As CNO, she ensures the quality and expansion of nursing services, the development of nursing policy, and continuing nursing education. Mary also works collaboratively to ensure joint commission and patient-centered medical home compliance throughout the Community Health Center. Building upon her services in various mission organizations, Mary continued to develop her passion for meeting the needs of the underserved. By earning her MSN at Yale University in 2005, Mary joined Community Health Center, Inc. as a family nurse practitioner shortly after graduation. While at Community Health Center, Inc., Mary has served as the on-site medical director of New London County sites, the vice president of the medical staff, and chair of the Pharmacy and Therapeutics Committee, and has served as a preceptor for the CHC Nurse Practitioner Residency Program. She earned a DNP at Johns Hopkins University. Mary is certified and holds professional memberships in the American Association of Nurse Practitioners. So Mary, I'm going to turn it over to you.
Perfect. Thank you so much, Lisa. Can you hear me okay?
Yes.
And I did my slides right?
Yes. It's all set.
Fabulous. Fabulous. Okay, great. Well, I'm so happy to be back with you guys. And as Lisa has already shared, it's been an interesting week. I'm about 48 hours without power thanks to our tropical storm, along with 600,000 other people in the state of Connecticut. So you are getting to see the lovely background of my office, because my office, in fact, has power. So I'm very excited to be here to talk to you about something that's very important and near and dear to my heart, which is sort of the process of care coordination. And of course, telemedicine and telehealth has definitely changed the face of a lot of what we're doing with regard to that. So as Lisa had said before, okay, advance, there we go. I have no conflicts of interest to disclose. And of course, you know, there is a huge educational need for information around care coordination, because many organizations, actually, most of their nurses are engaged in doing some form of care transitions or care management or care coordination, you know, prior to COVID-19 and prior to telehealth really taking off. And of course, much like any of our other implementations, it's filled with barriers and facilitators for successful process implementation enhancement. But telehealth has really kind of further complicated things, but also offered some great opportunities to either implement or to enhance some of the programs that we already have. So again, telehealth is fairly new for most centers, particularly in medical. So thinking about this with regard to care management is sort of something that's very new for a lot of us. So sometimes that shift in thinking can be a little challenging. I won't review our objectives since Lisa already did that for us. And just a quick reminder, our health center is located in the state of Connecticut. All of those blue dots are sort of our large brick and mortar sites, but we do have healthcare for the homeless sites and school-based health centers all across the state. We are waiting for the final on ensuring that all of our school-based health centers will hopefully reopen again in a few short weeks. School does not begin for us until the end of August. But you know, lots of interesting things going on, and lots of care models that we're engaged in. So, and each one of them looks a little bit different, particularly in the world of COVID-19. And also our Weizmann Institute, we do support and deliver educational interventions, as well as e-consults and other types of things all across the country. And we do have offices in Colorado and California as well. In another role, in my other life here at CHC, I'm also the clinical director for NEMA, which is the National Institute for Medical Assistant Advancement. So really great opportunities for you know, our goal always is that the rising tide should raise all boats. So if we figure something out, or even if we fail miserably at doing something in Connecticut, we love to share it, because we don't want others to have to repeat all the same mistakes, or to have to go through all the same thinking and iterations of process that we have had to. And in the last session that I reviewed, I did talk a little bit about patient-centered medical home model, because I do think it is very important as we're thinking about these processes that we are thinking about it with regard to the patient-centered medical home model, as most of us are either on the journey to becoming a patient-centered medical home or are already recognized. Or if we aren't seeking recognition, I know we certainly are thinking about how do we integrate all of these concepts into our practice, knowing that this is what's going to enhance not only the quality and the safety of the care that we're delivering, but also enhance the patient's experience. And as you can see in the patient-centered medical home with NCQA, two of the larger concepts actually fall into sort of this realm of care coordination. So care management and support, and then care coordination and care transitions. So this is certainly a process that all of us need to be not only implementing, but continuing to develop and refine you know, over the course of years. And frankly, we've been a PCMH for a very long time, but again, continue to improve and enhance our processes over time. That really is kind of the NCQA way of really, you know, start somewhere and then incrementally improve. And then, of course, in the last session, we did review the Tom Bodenheimer building blocks for high-performing primary care teams. And I just want to highlight three of those specific building blocks right now that also do kind of support and the implementation of care coordination. So that patient-team partnership with regard to kind of health coaching and overall improvement in care, barrier identification, all of those things that really fall into the realm of care coordination. Population management in many ways, care coordination, although it's a very individualized process, a lot of the interventions that we do are related to our population health department and actually identifying who are the high-risk populations that we really want our nurses to serve and to work with. And then last, of course, comprehensiveness and care coordination. So it isn't just about saying, here's your care plan, or here's what you need to do, good luck to you, and waving as they walk out the door, but really thinking about how do we scaffold our patients, how do we surround them with the support that they need to be successful. So now that we know, obviously, that care coordination is extremely important and that we absolutely need to be implementing it in some way, shape, or form, let's unpack it a little bit more by thinking about sort of what some of the overarching definitions are. So first, I think most people do use the ARC definition, deliberate organization of patient care activities between 2 or more participants, including the patient, hence patient-centered medical home, involved in the patient's care to facilitate the appropriate delivery of healthcare services. Now, in that definition, there's a lot of things in there, which is why I think many times, care coordination looks very different. If you've seen one organization do it, you've seen one organization do it. Some people have specific care coordinators, but then other people also subscribe to it being more of a process than an actual person, much like myself, and we'll talk about that in a little bit. But as I said before, it's an integral component of the NCQA's patient-centered medical home model. And again, also for nurses in particular, patient-centered care coordination is a core professional standard and competency for all nursing practice, regardless of what level of nursing practice you are engaged in. Okay, so let's talk a little bit more. What does care coordination include? It typically includes creating a comprehensive care plan. Now, don't be fooled by the word comprehensive, because I know care plans, I don't know about everybody here, but they sure scare the heck out of me, because most of our EHRs actually have very terrible care plans. So many organizations are actually using care plans that exist either outside of their electronic health record, or sometimes even using paper care plans, because they're just much easier to use when talking with the patient. So again, whatever your situation may be, don't feel like you're lagging hugely behind. We've been implementing our care coordination process since about 2014, and we still have not kind of mastered or figured out how we really want our care plan to look. Certainly our behavioral health department, by regs, of course, they are doing routine care planning. But the module within our electronic health record is just not, it's not conducive, I think, to that patient provider and patient nurse conversation of ongoing care. So we're really looking for better options. Creating that comprehensive care plan, you then want to think about making sure that patients can manage all different sorts of care transitions. Of course, the most common one is the transition from hospital to home. I think we have a chat coming in. When using a paper care plan, how do you incorporate this with the EHR? Yes, scanning. So definitely scanning is what most people will do, or they'll have people transcribe the care plan into a template or something. But again, people use a variety of different things. And of course, when you're scanning in a PDF document or just a paper form, you lose all of the data. And so then it becomes a much more manual process for tracking. And with care transitions, most people, I think, have mastered, or at least have a process that exists for sort of patient gets discharged from the hospital. How do we then recapture that patient into primary care? But some of the other transitions that happen within our systems, I think, maybe we don't necessarily pay as good attention to. So for example, when our patients transition out of our practice, is it simply just we send the notes to the next practice, or do we actually do some kind of a warm handoff to make sure that that patient's care can be picked up where they go along? I know for our organization, we actually have a value-based contract that once that patient is attributed to us, we own them for the whole year. So even if that patient leaves our organization 3 months into the plan year, we are still responsible to make sure that that patient's care management is taken care of. So doing that type of a warm handoff process is very attractive to us because it also, supports this value-based contract, as well as making sure that the next practice can just pick up where we left off. Sometimes that isn't as clear when you receive, sort of reams of paper of various different documents. Sometimes the care transition is from incarceration to home. That is something that happens very frequently in our organization, and these patients really struggle with how to sort of reconnect depending upon how long they've been incarcerated for. Sometimes it's going from a rehab facility or a skilled nursing facility back to home. We do have some families who might have a patient, in a long-term care facility and may decide that it's in the patient's best interest to then be moved to home. So again, these are all considered examples of care transition. So if you haven't maybe thought through some of the more common examples for your patients, it may be important to start to think about that and identify other categories of care transitions and sort of how your organization could better manage those. Then, of course, monitoring and follow up with patients about tests or medication changes. This one is a tough one because I think a lot of people don't necessarily count this as care coordination, but it really truly is a core function of care coordination. So every single time a patient has a test ordered for them, whether it's a lab test or a diagnostic image, how do you track and make sure that the patient has that done? I will say, even from my own experience in my own organization sorting this out, as well as having consulted with many other organizations, this is a very high issue with regard to FTCA and malpractice coverage. FTCA actually put out some really good information and guidance specifically around diagnostic image tracking because there are many examples of lawsuits where maybe a provider ordered an ultrasound for an abnormal mass or something, and maybe the result never got back from the hospital. Maybe the fax failed or something happened, and nobody really noticed that we hadn't gotten those results. And when that happens, you can absolutely have a miss that could create additional challenges for that patient that could result in a malpractice lawsuit. So tracking of images and labs is extremely, extremely important, but it's also very time consuming, particularly depending upon how often your providers are ordering imaging and ordering lab results. So that is also a part of care coordination. Then sort of the more common, function of care management is supporting patients and families as they manage their own care. So if you're a diabetic, really, how do I make sure I can take my medications from home, that I am improving on my diet and other things, helping patients to set personal goals. So self-management goal setting, motivational interviewing, all of those are sort of core functions of care management. And then aligning resources to meet the community needs. And that might be linking them up to community resources. Maybe they live in a food desert and don't have access to healthy food. Maybe they don't have any transportation. And particularly if you're a rural clinic, transportation could be a huge deal, right? Because there is no access to public transportation. So how do you even get to the place to be able to buy food or to pick up your prescriptions, even if you do them via mail-in, right? How do you get to the post office? How do you do all the things that you need to do if you lack transportation and you live in a place that doesn't provide that type of transportation? So all of these things actually fall under care coordination, which I think sort of lends itself to the statement where I say that care coordination isn't really a person, it's a process. Because as you read some of these, you probably are thinking of many different individuals in your organization that actually serve in these roles. So some of these things, you might have providers doing, or some of these things you might have your nurses doing. Still, some of the other things, like for example, diagnostic image tracking, you might even have non-clinical team members doing that, sort of the matching of orders and results. So there's really a lot of, I think, new thinking around sort of care coordination, that it's really owned by everybody. So that role definition is very, very important, that everybody knows that your job is to support the care coordination of this patient and the plan of care of this patient. But how do I know what are the pieces that I should do, and how am I best leveraged using my skills, my licensure, my talents, whatever it may be, to support the care coordination of the patient. And then, of course, you have the issue of, who really is ripe for care coordination, right? Lots of patients are potentially eligible. So when we look at high-risk patients, we tend to look at our patients with uncontrolled chronic illnesses, those with complex health, psychosocial, and service needs, folks who might have multiple providers. So the more specialists that they're seeing, it's very challenging, and sometimes you can get a duplication of medications or other things that can sometimes be at odds for treating various different conditions. Maybe people are in and out of the hospital or the ER, transitioning all the time. And so all of these things might potentially define somebody as needing care coordination. And so then we want to go back to thinking about this idea of resource allocation. So what really is the role of the RN in being a part of that discussion and a part of that care management? And what are the roles of other care team members to support that, so that you can really make sure that your RN is practicing to the top of their license and not necessarily taking on things that other staff could actually do on their behalf. Also thinking about the difference between sort of care coordination, case management, care management. There's a lot of these different words floating around in the literature when you look at sort of different models. And care coordination tends to be a term that kind of looks at the overarching model, whereas case management is very much seen as kind of a non-clinical function in the sense that case management is more about logistical management. So did the patient get from, to their cardiologist? Do they have transportation for that? Can they pick up their prescriptions? Things like that sort of fall under case management. Whereas care management oftentimes really is reserved for the level of care delivered by an RN, mainly because it can include medication titration. It can include various different assessments and decision-making around that patient's chronic illness. You also want to think about the role of risk stratification. As I mentioned before, at CHC, we have many value-based contracts. And so sometimes a value-based contract might shift a particular population as to who we think may actually be ripe for care management, or a specific group that we're going to be reaching out to. So be thinking about, if your payers have various different risk stratification models or various different populations that they want you to focus on, that may shift kind of your definition of care coordination and who's actually doing that. And I think particularly in a telehealth world, this is going to become more and more at the forefront as people are taking on more value-based contracts. A lot of this care is being delivered telephonically or even via video. So just a reminder, I know that many of your health centers don't have medical assistants there, but I do just want to clarify so that as I talk about some of the examples at CHC, you'll have an understanding of kind of why we've made the decision to have some work be done by the medical assistant and some specifically by the RN. So our medical assistants actually are the ones who do the majority of planned care. So when that comes to kind of chronic illness management, that means when a patient comes in for an in-person visit, they might get everything ready for the patient to have a diabetic foot check. They are going to, maybe schedule an appointment for retinal camera screening, although we aren't doing that right now because of COVID. If they're over the phone, they might coordinate for the patient to actually drive by just to get their fingers stuck for an A1C if that's due. So a lot of that is around logistical coordination. You don't need to be licensed staff to do that. So we have really leveraged this role in order to do that. And as I have said in our prior presentation, sort of that provider MA dyad is extremely important because we are juggling in-person visits as well as some being done via telephone and some being done via video. So managing the provider's schedule is extremely important. Our nurse visits are actually done mainly via telephone and video, except if it involves, of course, medication administration. Maybe it's a long-acting injectable antipsychotic, maybe it's Depo-Provera, maybe it's immunizations. Then those are actually managed by the nurse at the site. So we've actually seen that our nursing roles have really diverged a lot in the sense of what is sort of the telehealth role versus what is that on-site core nurse role, which I think we'll continue to see depending upon what your COVID model looks like and how much of your care is being delivered in the office. It's definitely going to impact things. We do have a face-to-face process, so patients do have to have a video visit first or a telephone visit first, and then if the provider then feels they need an in-office follow-up, then they will then book that visit. So we're really still quite low in terms of the percentage of visits that are being done on site. I think we are aiming in the fall to be no more than about 25% of our care being delivered in person, which again, is very challenging depending upon your access to Wi-Fi. Of course, we are much more urban, so a lot more of our patients do have access to really solid Wi-Fi, and we have lots of patients with smartphones and things like that. But we certainly do have patients who they're never going to be able to kind of leverage this because of either where they live or their particular situation. So we still do have to deliver care on site, but obviously your model may look different depending upon what patients have access to. We have also now restructured a few of our locations to create what we call telepods too, where a provider can actually come into the office so that they can have access to Wi-Fi, and the patient could present at any one of our site locations and have a video visit with a provider. So even if they're at one of our sites where we don't have, maybe there isn't room on the schedule for that person to be seen, they could have a televideo encounter with a nurse or a provider or somebody else where the provider might be at another site location. So again, depending upon your technology and your design, and how much sort of physical plant space you have at your site, you might be able to vary some of that. And as I showed before too, this is our dashboard where when the medical assistant actually sees things on the dashboard that are due for the patient, they can actually go ahead and just act on that as a part of the virtual rooming process or the in-person rooming process. And obviously if the patient isn't in person, then they would then book the in-person service, which could just be done as a part of a nursing visit. So if the patient was virtually having a diabetes follow-up, but they needed an A1C, they needed a foot check, they needed some other assessments, they would just book that as a diabetes visit with the nurse, and the nurse could then catch up, see how the patient is doing, perform all of those assessments, and then also check in to see if there are any other needs that the patient may have. Okay, so let's jump in, and sort of the last kind of 15 to 20 minutes of the presentation, I really want to focus specifically on the role of the nurse. So this was a slide that was presented before around our nursing role, really focused on patient education, treatment within provider visits, as well as independent nursing visits and standing order visits. And we'll talk a little bit about standing orders and delegated orders as well. They do the bulk of our motivational interviewing, self-management, goal setting, and of course, the care management process, along with triage. But again, we have sort of centralized triage in an effort to make sure that the majority of our staff nurses are really focused on care management. I put this slide in here. I'm not going to go over it in detail, but I did want to kind of put some bullet points of sort of the role of the CNO in primary care, because I do think it's important, particularly for larger health centers. If you have a critical mass of nurses, be thoughtful around whether adding a director of nursing or adding a chief nursing officer might be beneficial to your model to make sure that you can continue to advance your nursing model at your site. So I put that in here for people who are thinking about, maybe writing a job description or thinking about what the role of that would look like within their health center. Okay. So things that you need to consider when you're thinking about sort of your team roles, specifically for nurses. I think oftentimes there's a lot of push and pull between sort of centralization versus site level care. So again, as I mentioned, sort of the core nurse versus a centralized care management nurse who might manage patients telephonically or via video, et cetera, across kind of multiple site locations. So maybe you're a health center with 3 different locations. So if you have one nurse who covers all 3 locations in terms of diabetes management, for example, it would be very difficult, obviously, to do that in person. So how do you make sure that you can better leverage that nurse by utilizing a centralized model where telehealth and other things can really support that? Also, this push and pull between generalization and specialization. So we do have some nurses that are fairly specialized. Maybe they're an HIV nurse, or maybe they focus specifically in buprenorphine and medication-assisted treatment or diabetes. But then also making sure, though, that our nurses have enough generalized knowledge in order to be successful to care manage any patient. Ours is really a hybrid model in the sense that I said before, we have some centralized nurses, and then we also have nurses at the site, and some who are specialized and some who are very generalized. And so when I think about kind of the core primary care nursing care manager roles, it really comes down to sort of complex care management, specifically for subpanels of the provider panel, for either one or potentially multiple teamlets, depending upon what are the other functions that are on their plate. Managing, admitting, or discharging patients from your specific care management program. So for example, if you have a specific care management or care coordination program, it's important that you think about when is a patient officially quote unquote admitted to the program versus when are they quote unquote discharged from the program. Not everybody who's eligible for care coordination or care management is going to participate and be active in that care coordination or care management. So it's very, very important that patient engagement be a part of kind of your calculus when you're thinking about utilizing your nurses. Nurses are very expensive entities, so you really don't want to waste their services on somebody who might not yet be ready for change, right? That's a patient that you would then invest with motivational interviewing and say, hey, you know, when you're ready to talk about these things, I'm right here waiting. So you continue to remind them of those things and then continue to move on to patients who are really ready. One of the things that I feel like is a big miss that oftentimes happens in nursing models is we tend to give our nurses the most complex patients when really that's not the group of patients that's going to be most successful in working with a nurse. It's somewhere kind of in the middle. Patients who, you know, if you look at, for example, your end-stage renal patients, right? It's really good for them to have a nurse, but it's usually their dialysis nurse or their nephrology nurse who tends to be the one who's really supports a lot of their care management. But your primary care nurse, you know, really should focus their efforts on patients maybe who are a little bit more in between. Maybe their A1C is only like 12 and not greater than 14, right? Somebody who wants to change, who maybe has had better values, who they're likely to make better headway in terms of really evaluating, you know, what's going to move the needle on that patient's chronic disease control. This is very challenging for nurses, though. We love to save everybody. But the reality is that our resources are finite. So really making sure that you have a good process for identifying, you know, what patients are eligible for care management, and then how do you determine what dose of care management, if any, is sort of prescribed for that patient. Let's see. So standing and delegated orders, just a reminder here. A standing order is something that it's sort of a written policy document that applies to a large population of patients. I am going to go through kind of just briefly what are the steps to create a standing order, just so that you could theoretically take that slide away and hopefully begin to think about what that would look like for you to develop standing orders at your own organization. And then of course, delegated orders are different because they do apply to a specific patient. So it's, Bob came today, he had high blood pressure. I'm concerned, maybe I as the provider titrated their medication, and then I want them to follow up with the nurse in 4 weeks. If the blood pressure is still elevated, then please go, as long as the patient states they've been taking their medication, please titrate it one more time to this, and then have the patient follow up with me 2 to 3 weeks after that. So that's definitely a sort of more delegated because it's for a specific patient, not for a larger population. I did include our slide of kind of some examples of standing orders, as well as some of the examples of behavioral health types of visits, because our psychiatry team and our psychiatric APRNs actually also delegate specific nursing visits for some of their patients. Again, knowing that specifically our behavioral health prescribing colleagues do tend to be, again, another finite resource. And so one of the ways that we have successfully been able to expand some of the panels of patients that they're managing is by supporting them with a nurse to be able to kind of co-manage and support in some of the care management pieces for follow-up antidepressant visits and things like that. So the patient is still seeing that prescriber every, when they start an antidepressant, they'll still see them 4 to 6 weeks afterwards, but they might have a mid-telephonic visit with a nurse to make sure they got their medications, that they're having no problems, and to review the actual plan of care from the psychiatry team. So those are just some examples. Of course, for nurses to really be able to perform this successfully, they do need to have additional support. This is not something that was taught in their typical BSN program. They have one community course that focuses largely on public health nursing and home care nursing, but doesn't necessarily focus on all of the key competencies of care management. So you'll just see up here at the top of this slide, there's a list of different didactics and other things that we deliver to them through our complex care management program. So I'll just show a picture of it. So our nurses will join from their own laptops And now, of course, when everybody's remote, this is my best opportunity to be able to have FaceTime with my nurses. But we do this twice a month for an hour and a half, where we actually deliver didactic content and then spend an hour reviewing cases of complex patients that the nurses are sharing in an effort to kind of help them to build their competencies doing care management. So all of my nurses, regardless of how long they've been in the organization, they are invited to join this and to present their cases to get support from a multidisciplinary faculty. And just to give you a few other data points, most of our complex patients, they're not our frail elders. Like if you look at our data, the majority of patients that our nurses struggle to care manage are really within that 45 to 60 age group. They're younger, but still with, multiple comorbidities. They also, of course, our top medical diagnoses are hypertension, diabetes, chronic pain, obesity, asthma, and then comorbid depression, anxiety, substance use. These are the three big ones. So one of the, the best things that you need to do in terms of leveraging your nurses with regard to telehealth is to make sure that your nurses are prepared in managing behavioral health conditions from a nursing standpoint. How do they assess somebody's depression over the phone? Maybe doing a repeat PHQ-9 or other types of tools or models, but making sure that they are really well trained in suicide assessment. So that again, if they're unable to hand off to a behavioral health provider, that they can still deliver a high level of service to your patients and keep that patient safe. Okay, so let's just jump in real quick for standing orders. I think when you want to create your own standing order, which again, if you're going to be utilizing telehealth specifically for nurses to do certain types of visits, it's very important that you give them very clear instructions on kind of what is the minimum data set that they need to be collecting for every patient, how are they to document that, and then sort of what's the process for that with your patient. So in the standing order is really where you're going to outline all of those pieces. So who is going to do the work? If it's your registered nurses, how comfortable are they with doing that work, right? You need to make sure that they're trained and that they have all the guidance when you roll out a new standing order so that they can feel confident in it. Otherwise, their providers will see their lack of confidence, and that will really affect the provider's ability to kind of encourage that nurse to be a part of their care. When and how will the work be done? Is this an in-person visit? Is it telephonic? Is it televideo? And what do they do if the patient scenario actually varies from what the standing order allows? So, for example, if the situation becomes more complicated, are they to then triage the patient and send them to a higher level of care? Are they to send a message to the provider or immediately contact the provider? What's the protocol there? And are there any other considerations? So usually for standing orders, I typically go over 4 different types, but today I'm going to focus on 2, which is our planned care standing order and then chronic illness care management, just so you get a sense of kind of what these 2 standing order types would look like. So for planned care, our chief medical officer publishes what we call the clinical expectation for teams every single year. So again, goes over all of the standards of care, even for each chronic illness as well. How often should we be ordering an A1C or a microalbumin or whatever it is, giving certain immunizations, for example, our pneumococcal vaccines for diabetic patients, et cetera. And it's really from that document that we then create standing orders for our medical assistants as well as our registered nurses to say, these are the things that if this type of a patient walks through the health center, you do not have to ask anybody's permission to do this service. You just go ahead and do it. So for example, if a diabetic patient walks in and they have not received the pneumococcal vaccine, our nurse can just go ahead and deliver that vaccine. If the patient hasn't had a foot check in a year, go ahead and do the foot check. And if there's abnormalities, then here is how you act based on those abnormalities. So for these types of a standing order, you don't need kind of a large and thorough document. Most people actually will set up these standing orders as a grid. So they'll say, for A1Cs, this is how often they should be done. And the expectation is that if it's on your dashboard or if you notice that it's due, you can go ahead and act and complete it. So the staff member needs to know what's the denominator. So like who's included in the measure. The numerator, what counts in terms of completing the measure, what are the different actions that they need to take, and how often is the patient going to receive this service, as well as kind of the explanation of any data entry points or other follow-up or care coordination that's needed for the patient. So these are fairly simplistic. And like I said, I think the example of an A1C is probably the easiest one. So if a patient presents to the office and they haven't had an A1C in the last 6 months and, they, whether they're controlled or not, we would go ahead and we would do an A1C. If it's been 2 months, we wouldn't. But of course, we would know, is the patient controlled or uncontrolled? So we would know, do you have to come back in a month for your next A1C, or do you come back in 4 months for your next A1C? So all of that information is right there on that particular planned care standing order document. Standing orders for chronic illness care management is very, very different in the sense that this is a much larger document to write. And so I'm going to walk through this for our hypertension standing order. So first, you want to select your evidence and ensure that it matches your organizational and clinical expectations. So again, much of this for our hypertension standing order is around identifying patients with elevated blood pressure who still need the diagnosis of hypertension. So maybe they just need another blood pressure recheck to really determine that this patient in fact is a hypertensive patient. And it also, of course, applies to patients with the diagnosis of hypertension. And of course, so the standards are there in terms of what do we expect that blood pressure to be considered quote unquote in control. As a part of that as well, we put other standards in there for example, making sure that the nurse can actually prescribe on behalf of the PCP an automatic blood pressure cuff. Sometimes for our uninsured patients, we actually purchase them and have the nurses give them to a patient because we know, again, home BP monitoring is really a standard of care in terms of helping us to make sure that this patient's blood pressure is well controlled. We then outline kind of an expected data collection. So if this patient was being seen by a nurse, whether it was telephonically or in person, they would then determine, have the patient pull out their cuff, walk them through taking their blood pressure, sitting down, waiting a few minutes, making sure both feet are on the floor, talking them through the whole protocol, and then having the patient go ahead and take their blood pressure. They'll also ask them about their medication adherence or how has their diet been lately and other things that have relevance to their hypertension diagnosis. And at every visit for hypertension, they will ask that minimum data set. And then the rest of the standing order is really like an outline of optional data collection or care delivery based on the assessments that are completed. So I always like to think about this as kind of like a menu. So every time the nurse will see this patient, they will do X, Y, and Z, and then they have the option to add any of these other things. So for example, for hypertension, they are always going to check the patient's blood pressure and ask these questions, but maybe they're going to do a diet recall to better understand, what the patient has been eating over the long haul, because maybe they're very concerned about the amount of salt content that the patient has been consuming. Maybe they're going to do some teaching with regard to medication adherence, or maybe they are going to set a self-management goal with the patient. So all of these things are are an option of what the nurse can do in addition to that minimum data set. Another example would be asthma, right? That menu could include starting an asthma action plan or doing some inhaler teaching, or eventually, once we can have patients blow into machines, maybe spirometry. So these are all different options. And then you want to create a grid of examples. So who does this apply to? Are there any exclusions? How does the nurse know how to exclude those patients? And then, as I said before, what do you do if something else comes up? Like if the patient then brings up another complaint, maybe they say, oh, by the way, I've been having some chest pain. How do you make sure that your nurse can confidently triage that patient and address the other issue or complaint safely, even knowing this is a fully nurse encounter? So those are kind of the basic steps that you need to go through when you're developing your standing order. We'll talk for just a quick second about electronic tools. So again, dashboards, scorecards, templates, order sets, all of these things are electronic tools that will really help you, macros even, in documenting more efficiently, particularly when it comes to telehealth. And then of course, remote monitoring. I will say, if you haven't started remote monitoring, you're not far behind, because very few practices have actually started remote monitoring. And if anything, they're really starting oftentimes with blood pressure or glucometers, because again, the technology is much better around a lot of those types of tools. So for us, this is just how we access our data. So our electronic health record, actually, we dump our data into a data warehouse every single night. And then that is how we create our dashboards and scorecards and things like that. Some of you, if you're an Epic shop, then, Epic just does it magically for you. Someday I hope Epic will magically do it for me too. But unfortunately I am not on Epic. But other places sometimes have their data sync with Eye2Eye or other products that might actually, organize the data for them. But I think the moral of the story is you need to have access to data and think about how your systems support care management. So one of the things here is, of course, when our patients call in, our Novo system allows the person answering the phone to know who the nurse and who the medical assistant is of the patient. So if the patient needs something related to care management, they know exactly who to get them connected to. So it's not, so particularly if you have a team where you have nurses supporting particular providers, making sure that your front desk staff has that information is critical. Templates and order sets are very important. So in your electronic health record, if you can actually plan out, making sure that a template, for example, has that minimum data set to support the nurse to make sure that they collect it 100% of the time. This also makes sure that there's consistency in the documentation and that you can actually plan an emphasis on motivational interviewing and self-management goal setting as your nurses are kind of practicing those competencies. Oftentimes in an order set, you can even select appropriate educational materials that you could either text to a patient or print and mail to a patient, whatever is going to be most beneficial for your patient population that you're serving. And then of course, safety and efficiency, right? If you have a standing order that might include, for example, the prescribing of a blood pressure cuff or refilling of chronic medications, you want to make sure that that can be safely done in your health record without there being any kind of an error, and also quickly, right? Our nurses are very important commodities, very important staff members. We really want them to touch as many patients as possible. Because we know that the benefit of a nurse's touch in a patient's life is so wonderful in terms of being able to achieve chronic illness control. So I did also put a print screen in here. This is an example of our care management dashboard. So we have a dashboard that actually identifies high-risk patients for us based on either hospitalization within the last 12 months, ER utilization, diabetes or hypertension or asthma that are out of control, or 4+ chronic conditions. So wherever the yellow box lies, that is sort of the specific risk factor for that patient. And as you can see in our dashboard, we do also have a column, and I apologize, this is an older print screen, but we have a column for self-management goal setting. So we have structured fields for goal setting so that I know when was the last time a nurse actually set a goal with the patient. And then I could also tell if there's any specific action items for that patient. So our health record does allow for kind of what I like to call sort of tickler reminders. So the nurse can sort of put a reminder that says, oh, I'm supposed to call this patient in 2 weeks, and then it will disappear, and then it doesn't show up into their inbox again for another 2 weeks until that item is absolutely due. So really be thinking about how do you want to organize your data for your care manager so that they know who they're working with. We also developed a care coordination scorecard, which I think is important when you're thinking about specifically like performance appraisals and things like that, because you really want to make sure that your nurses are getting just-in-time feedback. So we designed that in coordination with our care coordination dashboard, defining who are the patients who are potentially eligible for care coordination. Other discipline-specific factors, maybe they're behavioral health patients, so there might be things that we look at. And you want to include both clinical and operational measures, and I'll show you the why in just a minute, and then link their data with the desired responses. So again, particularly in the realm of telehealth now, you're going to have to be rethinking what are the metrics that I'm using to really determine that my nurse is well engaged in the care management process. Oftentimes for phone calls in telephonic care, things are documented in, just in a narrative versus being structured data fields where you can actually collect something from the encounter that the nurse had with the patient. So really being thoughtful around what are the things that I can structure so that I could better understand, if my nurse spent time with these 30 diabetic patients, what are different about those patients or what are the same, so that I could potentially begin to look at that data to say, how can I determine who's going to be really successful in care management and maybe who isn't? Again, the more things that we're able to collect in a structured manner, the more we know about our patients and the more we know, some hints as to what might be beneficial for them. So this is, again, and this is an older version of our scorecard, but I think it, particularly since this was the beginning of our implementation, I really want you to see kind of the difference in the data. So this first picture is really what percentage of a provider's patient panel are eligible for care management. So as you can see, the green bar is the total potential eligible patients, but then the blue bar is who is actually enrolled. So one of the things to understand is that you certainly are never going to be able to get a nurse to enroll 100% of eligible patients into care management. There's just not enough time for that, and not every patient is going to be engaged. Next, when we looked at the scorecard, we wanted to look at total enrollment over time. And part of why we wanted to do that is we wanted to make sure that the nurses were engaged and continuing to sort of admit or enroll patients into care coordination. So as you can see, sort of the top 3 bars, over time, you continue to see those numbers go up incrementally because the nurses actually were continuing to engage new patients over time. Whereas you can see the 2 bars on the bottom, really have stayed pretty flat. So I know that maybe there's some training issues, or maybe there's some questions that I need to answer to better support those 2 nurses to be successful in care management implementation. Then we looked at enrollment by date. And part of why enrollment by date is important is because you really want to understand what can the panel size look like for your particular nurses. Now, panel size is challenging because you have to, the literature will tell you all kinds of things. Anywhere from 25 patients to like 250 is what I've seen. So it's very important that you kind of test this and track this over time so that you better understand your nurses, and with everything else that they have on their plate, roughly where are they falling in terms of the numbers of patients that they can manage. So as you can see, those top 3 nurses kind of leveled off somewhere between 30 patients and about 65 patients maximum. So I knew at that point that I wasn't going to be expecting my nurses to manage 150 or 250 patients at a time. I knew that they were very busy, and that likely between admitting new patients and discharging some patients from care management who maybe didn't need long-term care management, probably they were roughly each going to be managing about 50 patients at a time. The other thing that I will say too is clinical data is important to look at. So for a highlighted in red, this is one nurse's care management look for hypertension control and diabetes control. So as you can see, this nurse works with 2 different providers. So in the bolded line at the top, this is the average of the 2 providers. But it's important that nurses have this data in their hands. So for example, when we look at controlled hypertension, this is in the top line all the way to the right, you will see that one of the providers had a 78% hypertension control rate, while the other provider had a 61.1% hypertension control rate. So this actually allowed the nurse to know and understand and kind of look at these 2 different providers' practices and to say, how can, clearly the provider with 61.1% control rate needs more help from me. And how do I make sure that I can support that provider better? And what are the best practices that maybe I can learn from my work with the other provider to then leverage in this other provider's clinic? So again, making sure that there is data to support their discussion around utilization. Just a quick word about remote monitoring. What's available, as I said, there's lots of things that are coming down the pike, but a lot of them aren't necessarily integrated in the EHR as of yet. One of the most important things that you can do is actually make a phone call to your EHR vendor to get a sense of what are they doing in terms of remote monitoring. Are there certain things that are integrated, into their records already, et cetera. And then lastly, thinking about usability, whether the care is even reimbursed. Remote monitoring is reimbursed by CMS. And then of course, where do you start? And as I said, I think the best place to start is with your electronic health record, because integration with this type of data is very, very important for success. Okay, we did have a question that came through. Oops, sorry, I just changed that. Let me pull up the chat. Okay, what has been your biggest challenge with care coordination through this pandemic and turn to telehealth, and how have you handled it? So I think the biggest challenge for us was really getting into the habit of documenting telephonic encounters as a progress note versus documenting it just as a free text conversation. So that's really where templates and order sets come in very important, because they need to be imagining that they are in the room with the patient even when they're on the phone with them. And actually building the nurse's competencies to be able to ask assessment questions of the patient when they're not in the room, right? So thinking of, normally the conversations we would have in person, we would say, oh, well, why don't you show me what you're doing, right? So show me where you're injecting your insulin in your abdomen. Now you're going to ask the patient to describe it, right? And now you have to use new words to kind of help the patient to help you describe that. Just in the last part of the slide deck, I did just put some examples in here of kind of telehealth population health approaches. These are some of the recent things that we've done with regard to care management. So you can look at these. The slides will be coming out. I know Lisa's going to be sending them, but population health is a really wonderful place to start for care management with your nurses. It's really hard sometimes for nurses to determine, I need to do this work with this patient. So sometimes if you identify, as we did with this group, for example, we looked at our 8,000 diabetic patients and we said, who has an A1C greater than 9, who maybe has or hasn't seen a provider within the last 3 months? And then let's proactively schedule these patients with our nurses. So again, using your non-clinical staff to identify patients at risk who could really benefit from a check-in with the nurse. That really helps your nurses to stay on target and to make sure that they can spend the majority of their day making a difference for your patients. So the other examples, one is just on immunizations, and I put some data in there as well. And then ER follow-ups, as this is, again, a really great opportunity to make a difference and to connect with your ER patients, mainly because they're not going to the ER quite as much anymore because of COVID, but let's really keep them utilizing the ER for the most appropriate reasons. So Lisa, I know I left you 1 minute.
That's okay. So if anybody else has any questions, you can put those in the chat.
And in the slide deck, I did include my email address. So again, if you have a question, you can also find me on LinkedIn. People send me questions there sometimes too. So if things come up, yes, you're going to get a copy of the slides, of course. But I think, as I said, developing your care management process is an incremental process. Pick one chronic disease and start there. You don't have to solve everything all at once. But get your nurses engaged, whether it's diabetes or hypertension. We know that those are big hot topics on HRSA's list, and NAC's really supporting a lot of those efforts. There's a lot of work out there that you can apply and translate and have your nurses deliver that type of care that will be really beneficial for your providers too. If too much of this is left to the providers, oftentimes medications may not necessarily be titrated as quickly or as appropriately. I've really trained my nurses to say not, provider, what would you like to do? But actually come to the provider with a plan. If the patient's blood pressure is still uncontrolled, why not say to the provider, hey, I've done all of these things. The patient is taking their blood pressure. This is how they've been running. What medication do you want to add, or what medication do you want to titrate, right? Not to paint the provider into a corner, but to really say, listen, I've done a deep dive on this patient. I know that they need some more medication in order to be able to get to control. I've already prepped the patient. Patient already knows that they need this. What would you like to prescribe? That proactive approach with your nurses can make a huge difference for your providers in getting patients to goal quickly.
Thank you, Mary. I have opened the mics if anybody would like to ask a question, or if you'd like to make any comments. I also noticed there is one person that is on by phone. It would be extremely helpful if you would just put your name in the chat. That way I can look back at registration and make sure that you get a copy of the slides and the recording, as well as your CE information.
Lisa, Mary Beth wrote in and she said, one pearl of wisdom you've discovered for helping nurses see the benefit of their actions versus just extra work. And I think, Mary Beth, probably the best thing that I would say is ultimately, since adding the role of a chief nursing officer, I really get that opportunity to be their cheerleader all the time. And I tie back kind of the individual stories that nurses share when they make a difference with patients. And every time I'm talking about a new initiative, oftentimes, I will share with them and say, please, I want your feedback. I really want to make sure we can make this the most efficient. But as you know, this, like, our patients need this. They're dying of this. This is happening to them. And really making sure that they connect it to the mission of the organization is important. The other thing that I've also really showed, I think, in my leadership with the nurses is they've seen my ability to kind of measure things over time, and I've been able to add staff. So I think having a leader, whether it's, a CNO or a CMO or whoever, who's really going to focus in on your nursing staff, take the opportunity to really think about, how do I better calculate the impact of a particular nurse. And so if those nurses are getting overwhelmed and they're not able to meet some of their targets or make the difference that they're having with patients, prove that you need another nurse, right? Prove that the impact is there. Prove that the value is there because your quality data metrics are going up. I think that's really what I try to strategize with the nurses on, because I tell them, like, this is my plan. I would love to bring on, a nurse who focuses on this and a nurse who focuses on this. And I really want, to expand by this number of nurses. And I say, I want you to help me to plan and to move towards this. And I think as we've brought data to our CFO and to other places, we have had that ability to add staff. So I think my nurses hang in there sometimes with very challenging conditions, trying a new thing that maybe is just working out horribly, because they've seen the evidence that when they share their insight or their ideas, that I will act on that and that we'll try it, we'll try it and see if it works. Or if I know it's not going to work, or if for a regulatory reason it won't work, I explain that to them, right? But we work together. It's really, I think that's kind of the value of sort of like shared governance, right? They feel like they have a stake in what's actually happening. It's not just happening to them, but they are determining some of their own fate. So sorry, that was a long answer.
No, that's good. Perfectly fine. Thank you for sharing that. So we've come to the end of our time. That hour went really fast.
It sure did.
I know you could share probably forever. You have a lot of experience and some great words of wisdom that you've been able to share with us today. So it sounds like we're going to have you back again sometime to share some
additional. Love that. And someday if COVID disappears, I would love to come and visit some of your health centers and to see what your nurses are doing. I am definitely one of the biggest cheerleaders of the role of the primary care nurse, and, could talk for days about it, just as Lisa said. They really, I think, are the linchpin that we really need to get more activated across the country, to really make a big difference for our patients. We need more of them.
Thank you very much. And I appreciate everybody joining today. Hope you received a lot of great information, things you can take back and use, some templates that she shared through her slides. I will get the slides out. We'll get the recording out, and also an evaluation. So we'll appreciate everybody's input on that. There will also be a form that I'll need you to complete for CE, just so that we know that you're requesting CE and your credentials and information, so we can get that to you. So you should receive that in the next day or two, and look forward to you all joining us next Thursday at our next telehealth webinar, and it'll be at the same time. So if you haven't, if you know folks that would like to join, please let them know. We'd love them to register and be available next week, next Thursday at noon Central. So thank you, Mary.
Wonderful. Thank you all.
Electricity back on at your house.
I know. Fingers crossed. Take care, everyone.
Thank you.